Welcome to the Deep Dive.
Okay.
This is where we take a whole lot of information, boil it down, and pull out the key things you need to know.
That's the plan.
And today, we're tackling a really big topic, one that affects pretty much everyone in some way. Mental health.
It's incredibly common, but there's still a lot of misunderstanding out there, right? And navigating it can be tough.
Definitely. Still stigma attached,
Yeah.
unfortunately. So for this deep dive, we've gone through our source material on common issues in mental health.
And we're focusing today on two really prevalent conditions you probably hear a lot about: depression and anxiety.
Right. And we're also going to touch on substance use disorder, which, as we'll see, often ties in.
Exactly. Our goal here is to give you a clearer picture of how these conditions are assessed, how they're treated.
And some really important things for individuals and their families or support systems to keep in mind.
Yeah.
We've tried to pull out the most useful bits from the sources.
Okay, let's dive in.
So right off the bat, our source material points out something simple, but really profound. Common conditions occur commonly.
It sounds obvious, maybe, but it means if you're going through this or know someone who is, you are absolutely not alone.
Far from it. And
Yeah.
depression and anxiety, they're actually the #1 and #2 mental health issues seen in primary care.
Which makes understanding them just crucial, really, for everyone.
So let's start with Major Depressive Disorder, or MDD. How is that actually diagnosed? Not just feeling sad, right?
No, definitely not. It follows specific criteria from the DSM-5 TAR, that's the Diagnostic and Statistical Manual of Mental Disorders.
Okay.
And to help remember the symptoms, there's a common mnemonic: SIGECAPS.
Yes, SIGECAPS. Okay, let's break that down. S is for.
Sleep. That can mean insomnia, trouble sleeping, or hypersomnia, sleeping way too much, or just, problems staying asleep, not feeling rested.
Got it. And this is for.
Interest. This is a big one. It's either a significantly depressed mood or a real loss of interest or pleasure in things you used to enjoy.
And one of those has to be there for a diagnosis.
Yes, exactly.
Yeah.
Depressed mood or loss of interest, you need at least one. And interestingly, in kids or teens, this often shows up more as irritability,
Okay.
guilt, feelings of worthlessness, feeling really down on yourself,
Fun.
energy, just pervasive fatigue, feeling drained all the time,
See.
concentration, difficulty thinking clearly, focusing, making decisions. People often describe it as sort of a mental fog. Appetite. This can go either way: significant weight loss or gain, or maybe not enjoying food anymore. Psychomotor changes. This means either things slowing down thoughts, movements, feeling sluggish, or the opposite: psychomotor agitation, feeling restless and fidgety.
And the last S.
Suicide. Recurrent thoughts of death. It's important to mention that often these are passive thoughts, maybe wishing they wouldn't wake up, rather than an active plan.
Okay, so SIGECAPS.
Yeah.
And for an MDD diagnosis, you need how many of these?
At least 5 of those symptoms present nearly every day for the same 2-week period. And crucially, one of them must be that depressed mood or loss of interest.
Right. Okay, that clarifies MDD. Now, what about generalized anxiety disorder, GAD?
Very similar structure in terms of diagnosis.
Yeah.
It also follows DSM-5 TR criteria. And wouldn't you know it, there's a mnemonic for GAD too: watchers.
Watchers. Okay, let's do it. W.
Worry. But this isn't just normal worry. It's excessive worry, disproportionate to what's actually going on, and it tends to persist even after the thing you were worried about is resolved. This must be present.
Okay, must have worry.
Anxiety. Both the mental and physical feelings of being hypervigilant, on edge, keyed up. This also must be present for GAD.
Got it. Worry and anxiety are essential.
Tension in the body.
Yeah.
Muscle aches, maybe tension headaches, sometimes even stomach issues like GI upset. Concentration difficulty. Similar to depression, but often described here as the mind racing, hard to pin down thoughts.
Right.
Hyperarousal. That feeling of being easily startled, on edge, and irritability is really common here too.
Energy loss. Fatigue again. Feeling tired even if you've technically had enough sleep.
Right.
Restlessness. Feeling physically keyed up, fidgety, unable to relax.
And the final S.
Sleep disturbance. Classically with GAD, it's difficulty falling asleep because the mind is just going and going.
Okay, so for GAD, using watchers, how many symptoms and for how long?
You need at least 3 of those symptoms, occurring more days than not for at least 6 months. And remember, both worry and anxiety have to be part of that picture.
6 months. Okay. Now, you mentioned fatigue and concentration for both.
Exactly. There's significant overlap between depression and GAD symptoms. Sleep problems, concentration issues, fatigue, irritability, even appetite changes, or feeling physically agitated or nauseous. You see these in both.
Which must make diagnosis tricky sometimes.
It definitely can. It underscores how interconnected these conditions often are. It's not always neat little boxes.
So how do doctors, especially in primary care, sort this out?
Well, validated screening tools are really helpful. You've probably heard of the PHQ-9 for depression.
And the GAD-7 for anxiety. Our source material highlights a key point for success. Just knowing these tools exist is important.
You don't need to know every question.
Not necessarily, but knowing they're used for screening and for monitoring how someone's responding to treatment that's critical, they help standardize things.
Okay, so once a diagnosis is made, what's the goal of treatment? Just feeling a bit better.
Ideally, no. The primary goal is aiming for the virtual elimination of symptoms, getting someone back to their usual level of functioning socially, at work, in their life.
And how long does that typically take?
You often see significant improvement, remission, within about 4 to 8 weeks of starting effective treatment.
But you don't just stop then, right?
Absolutely not. Maintenance therapy is crucial. Continuing treatment for at least another 4 to 5 months after remission helps prevent relapse.
What if someone has, say, a second episode of depression?
In cases of recurrent episodes, yeah, long-term maintenance therapy is often considered to try and prevent future ones.
And is it usually just medication or just therapy?
That's a common misconception. Remission is actually most often achieved with a combination of approaches.
Like what?
Usually some kind of medication, plus psychological therapy like CBT or other talk therapies, and sometimes social support services too. It's really a multi-pronged approach that works best.
What happens if someone only gets partially better? An incomplete response, I think the source called it.
Yeah, that's a real challenge. Unfortunately, an incomplete response where symptoms improve but don't fully go away is linked to a higher risk of relapse down the road.
So really pushing for full remission is key for long-term wellness.
Exactly. It makes a big difference.
Okay, let's talk more about those pharmacological interventions, the medications. Our source had a pretty startling statistic about primary care providers.
Yeah, that primary care docs write for over 80% of all mental health meds.
Wow. So your family doctor is often the main prescriber here.
Very often. And the source notes a potential issue. Sometimes the doses prescribed in primary care might be too low or the treatment duration too short to be fully effective.
Interesting. So how is the right medication chosen? Is it just trial and error?
There's some of that, inevitably, but the choice is often guided by the person's most bothersome symptoms. Well, are they struggling more with what we call vegetative symptoms, sleep issues, appetite changes, low energy, fatigue? Or is the picture dominated by feeling really anxious and energized? That helps narrow it down.
Okay, so what are the main types? SSRIs are common, right?
Yes, selective serotonin reuptake inhibitors, SSRIs. They're generally good for lifting mood, kind of smoothing things out. Examples are fluoxetine, prazosin, sertraline, Zolofty, citalopram, Selexi, escitalopram, Lexapro, and paroxetine, Paxil. They vary a bit in how energizing they might feel.
Then there are SNRIs.
Right, selective serotonin or epinephrine reuptake inhibitors, like venlafaxine, Effexor, or duloxetine, Cymbalta. These work on both serotonin and norepinephrine.
What's the benefit of that?
They can also help lift mood, but the norepinephrine part often helps with focus and concentration too. They can be quite helpful for anxious depression, or if SSRIs haven't worked well and they tend to be more energizing.
Okay. Any other major classes?
There's also bupropion, Wellbutrin, which is an SDRI, selective dopamine reuptake inhibitor. It works differently.
How so?
It can be good for improving mood, maybe as an add-on if an SSRI isn't quite cutting it, or even on its own. It's often energizing. And then you have anxiolytics.
Those are for anxiety specifically.
They help mainly with the physical symptoms of anxiety, the hypervigilance, feeling on edge, things like benzodiazepines or Bizarre, but importantly, they don't usually decrease the underlying worry itself.
Got it. So when considering these meds, what are some key things people should know? Side effects.
Definitely. Sexual side effects are unfortunately quite common with many of these things, like difficulty with orgasm, erectile dysfunction, lower libido. The source says maybe 20–40% of people experience this.
That's significant, and probably a reason people stop taking them.
It absolutely can be. It's important to discuss with your doctor. Another really critical point is an FDA warning.
Yes.
There's an increased risk of suicidal thinking and behavior, specifically in children, adolescents, and young adults up to age 24 when starting these medications.
Wow, okay. But not in older adults.
Interestingly, no. The risk wasn't seen in adults over 24, and it actually seemed to be reduced in those 65 and older. But for younger folks, it's a crucial warning. Close monitoring is needed.
Good to know. What about how long they stay in the body? Does that vary?
Yeah, the half-life differs. Some SSRIs, like paroxetine, are cleared relatively quickly, maybe around 21 hours. Others, like fluoxetine, stick around much longer. Its half-life is 84 hours, plus it has a metabolite that lasts for 7 to 15 days.
So missing a dose of fluoxetine might not be felt as quickly as missing paroxetine.
Exactly. That long half-life can be forgiving if you miss a dose, but it also means it takes longer to clear your system if you stop it or switch meds.
You also mentioned drug interactions earlier.
Right. This involves the CYP450 system in the liver, which processes many drugs. Some antidepressants, like fluoxetine and paroxetine, strongly inhibit certain pathways.
Meaning they can affect levels of other drugs?
Precisely. They can cause other medications you're taking to build up in your system. Others, like citalopram, have minimal interaction potential. It's super important your doctor knows everything you're taking.
Okay. And there was a specific warning about citalopram, right? Celexa?
Yes, an FDA safety communication. At higher doses, citalopram can potentially affect heart rhythm specifically, prolonging the QTC interval.
So there are dose limits.
Yes. The max recommended dose is 40 milligrams per day for most adults, but it's lower, only 20 milligrams per day for people over 60, those with liver problems or anyone with a history of QTC prolongation.
Good to be aware of. Now, what happens if someone stops these medications suddenly? I've heard that can be rough.
It can be. It's called antidepressant discontinuation syndrome. It happens if you rapidly stop SSRIs or SNRIs, usually after taking them for at least 6 weeks.
Is there another mnemonic?
Of course. Finish.
Okay. F.
Flu-like symptoms, feeling achy, chills, fatigue, insomnia, trouble sleeping, nausea, sometimes vomiting, imbalance, dizziness, feeling unsteady, coordination problems, often described as brain zaps. Sensory disturbances like tingling, numbness, or sometimes vivid nightmares. Hyperarousal, feeling anxious, agitated, irritable. Also, headaches are common.
To finish. Sounds unpleasant. Is it dangerous?
It's definitely bothersome, sometimes quite distressing, but it's generally not life-threatening. It typically lasts less than a week.
And it can be avoided.
Yes, almost entirely. The key is to taper the medication slowly, usually over about 6 weeks, rather than stopping cold turkey. Always do this under a doctor's guidance.
Right. Okay, switching gears slightly, the source also mentioned second-generation antipsychotics, or SGAs. These aren't just for psychosis, right?
No, they're used for various conditions, sometimes as add-ons for depression or anxiety, bipolar disorder, etc. But some carry significant metabolic risks.
Metabolic risks, like?
Yeah. Weight gain, increased risk of diabetes, and changes in cholesterol or lipids.
Are some worse than others?
Yes. The source specifically flags olanzapine, Zyprexa, and clozapine, clobazaril, as having a high risk for these issues.
Okay. And others?
Others like risperidone, quetiapine, ziprasidone, aripiprazole, they tend to have more moderate or lower risks, but the risk isn't zero.
So monitoring is important if you're on these.
Absolutely critical. Recommendations generally involve checking weight, waist circumference, blood pressure, fasting blood sugar, and lipids at baseline. Then frequently in the first few months, like 4, 8, 12 weeks, and then regularly after that, quarterly, annually. It applies pretty much across the class.
Good to know. Okay, let's move on to substance use disorder, SUD. How is something like alcohol use disorder typically assessed?
A common quick screening tool is the CAGE questionnaire. Just 4 questions.
CAGE. What do they stand for?
C is for cut down. Have you ever felt you ought to cut down on your drinking?
Okay.
A is for annoyed. Have people annoyed you by criticizing your drinking? G is for guilty. Have you ever felt bad or guilty about your drinking?
And E.
E is for eye-opener. Have you ever had a drink first thing in the morning, an eye-opener, to steady your nerves or get rid of a hangover?
How effective is that?
Pretty effective for screening. 2 or more yes answers suggest a high likelihood of a problem. And you can adapt these questions for other substances too. Have you felt you should cut down on your drug use, etc.?
Makes sense. But for a formal diagnosis, it's back to the DSM criteria.
Yes. The DSM-4 defines SUD as a problematic pattern of use leading to significant impairment or distress. You need at least 2 criteria met within a 12-month period.
What kind of criteria are we talking about?
There are quite a few. Things like using more of the substance or for longer than you intended, wanting to cut down but not being able to.
Okay.
Spending a lot of time getting, using, or recovering from the substance, having strong cravings.
Does it impact daily life?
Yes. Often failing to fulfill major roles, work, school, home. Continuing to use despite ongoing social or relationship problems caused by it.
Using in risky situations.
That's another one, using in situations where it's physically hazardous. Also, giving up important activities, social, work, recreational, because of the substance use.
And then there's tolerance and withdrawal, right?
Crucial ones. Tolerance means either needing more substance to get the same effect or getting less effect from the same amount.
And withdrawal.
Withdrawal is experiencing characteristic unpleasant symptoms when you stop or cut back, or taking the substance or a similar one, just to avoid or relieve those withdrawal symptoms.
So 2 or more of that whole list in the past year. Does the number of symptoms matter?
Yes. It determines the severity. 2 or 3 symptoms is considered mild SUD, 4 or 5 is moderate, and 6 or more is severe.
Got it. The source also talks about codependence. What exactly is that in this context?
Codependence refers to patterns of behavior in family members or friends that get really entangled with the person's substance use. A key part of it is often enabling behaviors.
Enabling. Like what?
Making excuses for the person, say, calling their boss to say they're sick when they're actually hungover or high.
Why would someone do that?
Often, the short-term goal is just to avoid conflict, smooth things over. Or maybe providing money that gets used for substances, or even providing the substance itself.
But that doesn't help in the long run.
No, the end result is it kind of shields the person with SUD from facing the natural consequences of their actions, which can unfortunately delay them seeking help or taking responsibility.
What's the emotional impact on the person doing the enabling?
They often feel a lot of guilt, anger, maybe depression themselves. They might feel responsible but unable to fix the person, and sometimes struggle to see SUD as a genuine illness that needs professional treatment, not just willpower.
That sounds really difficult. Okay, finally, let's touch on a very serious risk. Opioid overdose.
Yes, a critical issue. Overdoses can happen for several reasons. Deliberate misuse, obviously, of prescription or illicit opioids like heroin or fentanyl.
But also accidental?
Yes, miscalculating a prescribed dose, or perhaps taking an extra dose accidentally. And a huge risk factor is using opioids with other things that slow breathing, especially alcohol or benzodiazepines.
Is that the warning you mentioned earlier?
There's a specific FDA-boxed warning. Combining benzodiazepines, like Xanax or Valium, and opioids can be fatal because they both suppress respiratory drive.
So who is most at risk of an overdose?
Several groups. People on long-term opioids for chronic pain, anyone using illicit opioids, people misusing prescription opioids. Also, and this is really important, people who had tolerance, then stopped using for a while, maybe during treatment or incarceration, and then start again. Their tolerance drops and their old dose can now be lethal.
That's scary. Any other high-risk situations?
Yeah, people on rotating opioid regimens where doses might get mixed up, anyone discharged from an ER after an overdose, completing detox, or recently released from jail with a history of opioid use disorder, these are all very high-risk periods.
What can be done to prevent these deaths? What are the strategies?
Several key things. First, increasing knowledge about prevention and management for everyone. There are resources like the Providers Clinical Support System, PCSS, and websites like preventprotect.org.
Okay, what else?
Ensuring access to effective treatment for opioid use disorder itself, using medications like buprenorphine or naltrexone. SAMHS has a treatment locator online.
And what about reversing an overdose if it happens? Naloxone.
Absolutely vital. Ensuring naloxone Narcan is a common brand name is readily available. People with SUD, their families, friends, anyone who might be around them should ideally carry it and know how to use it. Prescribetoprevent.org has info on that.
Any system-level things?
Yes, using state prescription drug monitoring programs, or PDMPs. These databases track controlled substance prescriptions, helping doctors and pharmacists identify potentially risky patterns.
Okay, that's a lot of ground we've covered. From understanding depression and anxiety with SIGECAPS and watchers,
to the nuances of medication, side effects, discontinuation, and metabolic risks.
and then digging into substance use disorder, CAGE, the DSM criteria, codependence, and the critical issue of opioid overdose prevention.
So when you pull it all together, understanding these common conditions, how they show up, how they're treated, the risks involved, it really does empower us, doesn't it?
Yeah, I think so. It gives you, the listener, hopefully more knowledge, maybe more empathy.
It might help you recognize signs either in yourself or people you care about, and maybe foster, a more open and informed conversation about seeking help, about providing support.
Ultimately, just contributing to a better understanding of mental health and well-being overall, which is something we definitely need.